Thanks everybody for coming along, taking time out of your days today. I'm Anna, I'm consultant clinical psychologist at Framework based in Nottingham Recovery Network. Emily?
Hi everyone, I'm Emily, trainee clinical psychologist, currently on placement within Nottingham Recovery Network with Anna.
And yes, we'd like to talk to you today about learning disabilities generally and the Learning Disabilities and Homelessness Toolkit. So most of what we're going to say today is actually within the toolkit. So if it's one of those things that you're never going to get around to reading, hopefully this will at least give you an introduction to it. So we're going to talk about what learning disabilities are. We're going to talk about how to recognise them and screen for them, also how they are diagnosed, although most of you probably aren't in a position to diagnose yourselves. Talk about adjustments to support, accessing statutory services and support, and a little more about the toolkit and kind of a bit more about what you can do as well. We are going to talk a little bit in today's session about modern slavery and violence against people with learning disabilities. So just a bit of a heads up that will be in there. Okay, so to begin with, I think it's really important to just talk about what learning disabilities are, because I think there's a lot of misunderstanding about that. So they're also known as intellectual disabilities, which is not very helpful because obviously having two terms for the same thing can cause confusion. But what we're talking about with either of those terms is somebody having significantly below average IQ, so thinking skills are significantly below average, and also significantly below average kind of daily living skills, and we'll come on to what that means in a bit more detail. Also, those difficulties have got to have been there since childhood and not caused by some kind of childhood illness or accident in childhood. So they have to be there right. There have to be concerns about someone's development right from their very early years. What we're not talking about is what are sometimes termed specific learning disabilities, so like dyslexia. We're not talking about autism or ADHD. So people with learning disabilities may have those diagnoses, but also people with those diagnoses don't automatically have learning disabilities. So really important, what we're talking about is what used to be called global developmental delay. So it's kind of cognitive impairment that impacts somebody kind of across their skills and is, there from very early on in their life. So it's also useful to look at the Department of Health and Social Care kind of diagnosis or definition, which talks about a significantly reduced ability to understand new or complex information, to learn new skills, impaired intelligence, with a reduced ability to cope independently, so impaired social functioning, which started before adulthood. So this is not to say that people with learning disabilities can't learn new things or can't develop skills, but they're going to need a fair amount of additional support compared to peers of the same age when it comes to learning new skills or information. So there's also categories according to how kind of severe somebody's learning disability might be, and these are based around the IQ range when somebody has an IQ assessment. So mild, moderate, severe or profound, really within homelessness and substance use and related services, it's most likely that you'll be in touch with people with mild learning disabilities, because usually for people with severe and profound learning disabilities, that will have been obviously identified from very early on. They're likely to live in supported living or care home accommodation. They're not likely to come into contact with homelessness services, and they're also very likely to have ongoing social care kind of involvement or packages and funding that have been there since their childhood. You will occasionally find that people with moderate learning disabilities come into contact with homelessness and substance use services as well, but often we're talking about those people with what's termed mild learning disability. But what's really important is to know when a psychologist does an IQ assessment, even if somebody is scoring mild, actually they might be functioning less well than 98% of their peers. So the other thing that's really important to kind of set the scene and help you think about, considering learning disabilities when you're working with people is that they're very much not visible. So I did a Google search to check whether this was still the case when I was putting these slides together, or whether representativeness may have developed online. But if you Google search adults with learning disabilities, you almost exclusively get pictures of adults with Down syndrome, so very physical characteristics that are very visible. But that isn't at all representative of the broad range of individuals who have learning disabilities. So I was thinking about some of the people that I've kind of worked with or diagnosed when I worked in learning disability services prior to coming to Framework. And they include the kind of the 6'3" man who likes to wear a high vis jacket because people sort of respect him and leave him alone. They assume he's a workman. They don't, he's much less vulnerable. They don't kind of hassle him. And he can kind of fit in much more easily. They also include a father of 3 who are diagnosed after his partner, long-term partner and mother of his children, got a job as a support worker in a supported living accommodation for people with learning disabilities. And she said the penny started to drop about some of the difficulties he had as she worked with people and learned more about learning disabilities. And she'd done a lot of the kind of household chores. She did all of the reading. She knew that he struggled with reading, but she offered so much support, and they'd just never assumed that he had a learning disability. And it was only when she learned about them that it kind of clicked into place. Also older adults who maybe have lived with their parents for a long time often come into contact with services for the first time when their parents are aging, or get ill and are no longer able to care for them. That sometimes is where it becomes apparent that somebody's really struggling and can't function independently. And that includes people who have jobs. There's no reason people with learning disabilities can't have jobs. And I think particularly for older people, they may have got jobs when the kind of employment context was quite different. People, and in local and more rural communities, people maybe kind of supported people that weren't doing so well to get a job, and they stayed in those jobs for a long time. And again, that's part of kind of people not assuming that there is a problem there, but actually if some of the structures around the person, like parental support or partner support, get removed, it becomes very quickly apparent that they can't cope very well on their own. It includes people who are alcohol dependent or use other substances, and it includes people who take pride in their appearance. It can include people who are very verbally competent. So when we do IQ assessments, one of the things we look for is kind of verbal abilities and comprehension. And sometimes people can score reasonably highly on that, and they're really able to mask some of their cognitive difficulties, either by kind of agreeing, or if you ask, do you understand? They say yes, but they don't really understand. And if you try and test it a little bit more, it's clear that they don't. So I think I really wanted to make this point because it's easy to rule out learning disabilities because people have a job or look a particular way, or or it's never been raised before as a possibility. But it's really important that we sort of challenge those assumptions if we've got some of the kind of worries that we'll come on to talk about that might highlight the potential for learning disabilities. And in terms of prevalence, here are some figures from MenCap. So we're talking about, a fairly significant proportion of the population have a learning disability. And of course, that's people where it's recognised, diagnosed, but there are many, many people who have hidden learning disability as well. And we know that if you've got a learning disability, you're disadvantaged in a number of ways. So, of course, your educational attainment is going to be likely impaired. People may recognise in school that you're having difficulties and you may get additional support. But I think a very common trajectory that I've seen is that you become the sort of naughty child or the class clown. You're very able to mask that you're struggling through your behaviour, but you get seen as having behaviour problems, and maybe you get excluded very early, or people don't really show you the extra interest and support that you need. And so often people will have dropped out of school or sort of left school without any kind of qualifications. Disadvantaged in terms of work opportunities. Obviously, even just the process of trying to apply for a job is difficult if you struggle with reading, writing, cognitive ability. You've got increased reliance on benefits and public housing as well. Your social status, your ability to kind of join in with activities in the community is likely to be reduced as well, unless you have that support in place. You're more likely to live in poverty. You're more likely to have health inequalities, and that includes a lower life expectancy and greater risk of dying from avoidable causes. And if I think about some of the people that I've worked with, that includes, for example, having do not resuscitate orders put on you without any conversation with yourself or your family members by doctors. So there's a lot of stigma, discrimination against people with learning disabilities, a lack of involvement of them in their own care. There's also lots of kind of myths and assumptions about things like people having a higher pain threshold, but we know that people aren't able to kind of either recognize themselves or articulate their kind of physical health experiences and access support in a way that people without a learning disability are. So for that reason, people are much more likely to have physical problems that reach more severe points because they're less likely to access kind of early help and intervention. Okay, I'm going to hand over to Emily at this point.
Thank you. Yeah, so I guess we're just looking at how to recognise learning disabilities. Anna had mentioned there that learning disabilities aren't always visible. So sometimes we can make assumptions that because somebody attends appointments or can kind of keep to the same appointment time and things like that, that actually they don't have a learning disability, but that's not always the case. So I guess you might notice some difficulties related to understanding information. And I think Anna mentioned that can be new information or complex information. So it's not to say that people can't kind of take in any information, but it's the level of complexity with which they can do so. Perhaps some difficulties related to reasoning skills in appointments as well. Things around working memory, so using a small amount of information long enough to complete a task. And this is something that you might notice sort of in ongoing sessions. So it might not be in a first meeting with somebody or the first time you meet somebody, but sort of ongoing, it might be something that you recognise over a period of time. And needing more time to process information, and that could be either the length of time that it takes them to understand what has been said or the processing of that in how much information is given to them and how that information is disseminated as well. So do you notice that actually if you give something in a shorter sentence in smaller chunks, then it's easier for the person to process the information? Or does it need repeating over a period of time? So there's some, I guess, nuances there as well. Could you go to the next slide, please? Thank you. There's also, I guess, potential difficulties in daily living skills. So this is a list of all of the areas that are assessed, which I think we'll talk a bit more about later. So just to go through some of those, as Anna said, somebody might verbally communicate very well, but actually another element of daily living skills somebody might really struggle with, but it just isn't apparent straight away. So accessing and using the community is something that I always found sort of didn't come to the surface straight away when I was working with people with learning disabilities. And this could be something like getting public transport, using cash machines, those sorts of everyday things that we might just assume people are able to do, but actually people with a learning disability might just avoid them, and then their access to the community is much more limited. But I guess it doesn't seem as obvious as something where, like verbal communication, if there were kind of obvious difficulties there, that would be more prominent straight away. Sort of day-to-day maths and literacy, so understanding money. I think a big one, again, I always came across was people not understanding change when they pay for something. And then sometimes that could lead people to just either not buy anything or give the money and then leave without checking their change. And that could lead to an sort of an ongoing I guess, yeah, difficulty of reinforcing it in a way. So just not having any support in that way. Home living in whatever circumstance. So as Anna mentioned, people with learning disabilities do have experiences with homelessness. So I guess this is thinking around the importance of hygiene, eating well, and the understanding of things like that as well. And then I guess the rest of the list, there's health and safety, leisure, self-care, self-direction and social relationships. And I think it's just important to say that people with learning disabilities might have difficulties in every area, but there are some areas that people might have strengths in and struggle with other things more. So yeah, it's kind of not the same across the board for everybody, which I think is important to note. In terms of thinking skills, somebody with a learning disability might take a long time to answer questions or avoid you asking them questions. So just kind of talk at you a lot without a break or without that gap for kind of those reciprocal questions to be asked. They might not be able to focus their attention or remember what you've said or recognise social cues. So hints that the conversation is coming to an end. As we've mentioned, it might take longer to learn new information, or they might, become frustrated when lots of information is given because they're not understanding or processing what has already been said. And then if more information is coming, it's hard to just kind of allow them to process that. And that frustration could turn into aggression, which is, I guess, just displaying that they're unable to take in what you've been saying. I think have we moved on? Yeah.
Sorry, was that too soon?
No, that was fine. Thank you. So as a professional, you might find yourself having to explain things again and again or in different ways because somebody just might not seem to be getting what you're saying. You might find yourself becoming frustrated that somebody doesn't seem to know or remember what you've already told them. And you might just notice that they struggle to solve problems logically. And also you might find yourself giving more reassurance or support than usual, even for basic tasks. And this could be, I guess, around aiding memory, how to remember appointments, remembering what has been done in sessions or discussed in sessions with somebody. And I guess just thinking about whether they're responding based on what they have remembered or just responding. I think, as Anna mentioned earlier, just to say yes, that they've understood it, or yes, they can remember what has been done previously rather than actually understanding. And this can lead to social vulnerability for people with learning disabilities, often called mate crime. And this is a form of disability hate crime. And this is something that describes people befriending people with learning disabilities for exploitation. And this can be including being defrauded or made to give money, cuckooing, so having the home taken over, being used to commit crimes for other people, and sexual exploitation. And these can all contribute to homelessness, contact with the criminal justice system, and mental and physical health problems. And I think it's just worth saying that sometimes these sorts of crimes can be over a really long, sort of sustained period of time, but they can also be sort of ones that you probably don't hear about as much. So an example that I had from somebody I used to work with was they'd built up a trust with their hair salon. They were known very well there. They used to pay in cash. And then it got to a point where they were not being given the right amount of change because they knew that that person wouldn't understand the money that they were receiving back. And that went on for quite a long period of time. And it was only when their support realised that that was kind of noticed. So it can be kind of either end of the spectrum of really, really sort of long and sustained and lots of money and being defrauded, but also kind of on the what you might consider the minor end, but it's still somebody being exploited because of their difficulties.
Thanks, Emily. And of course, all of these kind of offences aren't just disability hate crimes. They're not just against people with learning disabilities, but people with learning disabilities are more vulnerable to them. And that's what we want to kind of really highlight, that sometimes we won't necessarily be thinking, has this person got a cognitive impairment? But actually, if people are being exploited in this way, it may not just be because of dependence on substances, which I think is often the assumption, like they're vulnerable because of their substance use and they're doing things to fund their use, for example. But actually, it might be that they've got an underlying vulnerability. And sometimes substances may have been introduced actually by the people exploiting the individual as well, as a way of kind of controlling them. So we're not going to talk in detail about this, but I think it's worth saying that kind of modern slavery and learning disabilities is being increasingly kind of recognised. The Snowdrop project, which is a Sheffield-based project, have produced this report that you can see on the left, and you can access that and read it. So they ran a learning forum with the Human Trafficking Foundation to talk about some of the concerns about essentially learning disabilities not being recognised in modern slavery. And actually, there's a sense that people aren't aware enough, so professionals that are working with modern slavery aren't aware enough of learning disabilities, what that means, but also we're not capturing the data. So there's the national referral mechanism where somebody's been involved in modern slavery, but that doesn't even capture at the moment, doesn't collect the data about whether somebody has a learning disability or not. So this is likely a much kind of hidden and misunderstood kind of issue, really. But it's starting to gain more attention. And in Nottingham, the Rights Lab based at the University of Nottingham carried out this research that I've put the link to on the right, which again highlighting the kind of intersections between exploitation and cognitive impairment. Of course, cognitive impairment can be because of dementia or brain injury as well, but they included a focus on learning disabilities and again, just highlighting the fact that we need to be considering this when we're working with people who are experiencing exploitation. There's been a few very high profile cases fairly locally, but the case of the Rooney family in Lincolnshire, so 11 members of the family were jailed for a total of 79 years for keeping people who were homeless, some of whom had learning disabilities, and also people who were alcohol dependent. Again, there's that kind of potential overlap between those groups. But in one case, somebody had lived with them or been kept by them for 26 years. Interestingly, the longest sentence given was 15 years for any of them. But they, people being kept in squalid conditions, forced into working for them, labouring for them. They used drink and drugs as a way of controlling people, so giving people drink and drugs, but they also used threats of violence as well. And then the case on the right is a local Nottingham case where a woman with learning disabilities was held for 5 months by, although it emphasises the couple here, they also, a friend of theirs was also involved. So 3 people were charged with stealing her benefits, assaulting her on a daily basis, and forcing her to work for them. And I think, it's sort of painful to look at, but I think it's really important to think about what does this actually look like for the people who are involved. We're talking about kind of, I find it difficult to believe that there are cases like this where someone can be essentially missing for 5 months, even, never mind 26 years, being exploited in these kinds of ways. But it's people who slip between the cracks, who services don't really have an eye on, whose families maybe are, estranged. And, I think it's really important to highlight these are not kind of long ago cases. These are fairly recent, and it's worth kind of holding this in mind. So we want to think about how to screen. So for most of you, I can see 1 or 2 psychologists on the call, but for most of you, you probably won't be able to diagnose, but you can screen. So your starting point is if you suspect that somebody has a learning disability. So some of you might have sat and listened to kind of Emily talking through what some of the kind of characteristics are or what you'd be looking for. And you might already be thinking, I've got people that I'm working with at the moment who might tick some of those boxes. I think the starting point is thinking about whether and how you raise it at all with somebody. Of course, it's a really sensitive subject. I think it's got connotations. So I think, somebody who may not have learning disabilities might think if you raise this as a possibility that you're saying that they're stupid, or that you kind of think that they've got some kind of deficit or defect. So it needs to be kind of raised really, really sensitively, hopefully by somebody with a trusted relationship with that person, and thinking about how, based on your relationship with them, might you start that conversation. So actually, do they prefer very direct communication, and you might not cause offence at all, or might you start with talking about the fact that you've attended this webinar and you've wondered whether anyone's ever kind of mentioned that with them. I think sometimes you'd be surprised by people's response, and you might find that they instantly tell you that this was an issue for them. But actually, there might be other things that you can do to kind of subtly get there without even mentioning learning disabilities to start with, so that it's more sensitive. So the first thing is whether the GP has a record of learning disabilities. So if you're able to seek a GP summary, if somebody has been diagnosed in childhood, that should be on their records. That's not always reliable, and of course they may not have been registered with the GP, or records may not have followed them, but that's a good starting point. Then kind of having conversations about school and what school they went to, and looking out for whether that was a mainstream school or a special school. So, actually sometimes you can just Google even some of the special schools that aren't around anymore. I've been able to find when people have told me what school they've gone to, and I've not wanted to yet talk to them about whether they might have a learning disability. Google the school and find, yes, that was a special school in the area that they were living in at the time, that they would have been school aged. So I think you can do a bit of kind of background detective work so that you can help yourself feel more confident if you're feeling nervous about introducing it to them. Do they have any qualifications? So the minute somebody has any GCSEs or A levels, I would tend to be ruling out learning disabilities. It's not impossible, but I would tend to be ruling it out as a likely explanation for their difficulties. Have they ever worked? And if they have, thinking about what sorts of jobs they have. So when I worked for Knott's Healthcare, I was referred somebody for a learning disability screening. They'd worked in a call centre for 7 years. There's no way they had a learning disability. You just would not be able to do that work with that kind of level of cognitive impairment. So thinking about, if they've done labouring, if they've done kind of very manual type jobs, it doesn't rule out learning disability at all. If they're doing kind of more skilled jobs or things that require qualifications, then it's much less likely. Have they ever run their own tenancy? So when I say run it, I think what's really important is to think about if they've lived with a partner, then I would not consider that running your own tenancy. So partners, parents, friends do a lot of kind of covering up people's difficulties, in the sense of not deliberately covering them up, but compensating for them. And so actually the learning disability is quite hidden. But do they actually pay their own bills? Do they set that up? Do they know how to fix things when things need repairing? That's one of the questions that we'd be asking in assessment, kind of what do people do when something's gone wrong in the house. So those sorts of things, have they run it? Not just have they lived in a tenancy with somebody else, but have they actually managed that day to day? And then sometimes the way people talk about themselves gives you a bit of a clue as to whether they might be struggling. So people might call themselves thick, or say other people have called them that. Obviously, that's not a word that we would use, but people will use that about themselves, or slow, or stupid, or worse terms. People might be very open about the fact that they struggle, that they can't read or write, but of course not being able to read and write in itself does not mean that you've got a learning disability. But that might be part of the picture. And some people with learning disabilities can read and they can write, reasonably well for kind of day-to-day things. So it doesn't, again, you've got to be fairly careful, and it's getting the whole picture that's really important. And then do they seem kind of isolated or socially vulnerable? So some people may not be isolated at all, but you might have real concerns about their kind of friendships. And there's also a learning disability screening questionnaire, which might be helpful if if you're still struggling after kind of thinking about these questions as you get to know somebody. Then there are specific short screening questionnaires. One of the things you might want to think about as well as driving. So particularly if somebody's fairly recently managed to get a driving license, the chances are they don't have a learning disability because the theory test is so demanding now. But thinking about, the 54-year-old man that I mentioned, he did drive. He'd qualified at a time when things were a lot less tight in terms of your theory tests, and he'd always had his license and no one had ever kind of questioned it. So, there are people around who have a learning disability who've been driving for a long, long time. But I think now if someone's younger, the chances are you wouldn't probably make it through the theory test. So once you've screened, then you might be seeking a diagnosis. So a diagnosis requires an IQ assessment. So that's done by a psychologist. An adaptive functioning, so that's your daily living skills assessment. That tends to be done either by the psychologist or an occupational therapist, but also it's often done as a kind of checklist. And so there are limitations to that assessment in the sense that if people have been in prison a long time or in hospital a long time, or if people have been street homeless for a long time, a lot of the questions it's not going to be possible to answer them because they're based on a kind of assumption of daily living within a context of having a home, of being able to kind of access the community, etc. So what I would say is sometimes that assessment, like thinking about adaptive functioning, might need a lot more thought for somebody who's facing severe multiple disadvantage. And then also early developmental history. So often that's really difficult as well for people who are street homeless or experiencing severe multiple disadvantage, excuse me, or estranged from their families. The ideal, let me just cough for a moment, bear with me. It's a good thing about being online and not face to face, isn't it? Is that I can mute to do that. But the ideal would be that you would ask parents for somebody's developmental history, but often the population that we're working with, either their parents have passed away or aren't accessible, or they don't have a relationship with them anymore. So again, this can be really difficult. People won't know whether they've met their own milestones kind of before the age of 5 and those sorts of things. And so sometimes we have to take a bit of a best guess at that based on the IQ assessment and adaptive functioning. So to get a diagnosis, you might first start by asking for a referral to community learning disability team within the NHS. Sometimes that's via a GP. Sometimes they'll take direct referrals, so you need to check with local services. But what I would say is that they will only likely carry out that assessment if people are struggling in some way. So people services won't just do an IQ assessment or a learning disability assessment for the sake of it if somebody's doing okay. So you really need to make the case that they're struggling. Often that's going to be fairly easy if somebody's in homelessness services, if they're hugely socially vulnerable, if there's safeguarding concerns, if their behaviour is very challenging in whatever way. So aggression or offending behaviour, it might be fairly straightforward to make that case. But just to be clear that you'll be unlikely to be seen for assessment if there's not something going quite wrong for somebody in day-to-day life. I think it's also really important to highlight that, community learning disability teams might well not be aware of NICE guidelines for homelessness. So if you're working in homelessness services, even if you're not a learning disabilities expert, don't hesitate to kind of share guidelines that might be helpful, or substance use guidelines, those sorts of things. So, they might encourage greater flexibility in terms of appointments, in terms of how the person's approached, those sorts of things. They might make it more likely that somebody can actually get to the point of being assessed. Of course, someone's got to consent to assessment as well, and they may not want to. I've assessed a few people since I came to Framework and found that actually, for some it's been very helpful. For some, it's just confirmed what they already thought. And for others, actually, one in particular, it was very disappointing when they didn't meet the threshold. And actually, they were more kind of on the borderline, but they didn't meet the threshold for learning disability. And that was really difficult for them to come to terms with. So you also want to think about what function is assessment diagnosis going to serve? Is that going to be helpful for them or not? It might not be helpful for everybody. And if somebody isn't bothered, they're probably not going to go through what's a fairly grueling assessment process. So the IQ assessment bit takes at least an hour. It's lots of different kind of games, puzzles, tests, questions. And if you've got somebody who will really struggle with that sort of process, or who's dependent on substances and can't kind of have any break from being dependent on substances, it might make that assessment very difficult for them, but also not necessarily valid either. So we're only going to really think about diagnosis for people where it's really going to make a difference to them. What is helpful is that, you don't necessarily need to have a diagnosis for us to start thinking about what adjustments people might need. So even if we suspect learning disability, we can start making adjustments. So we've got the requirement to make adjustments. This is a disability. So in terms of the Equality Act, people should have adjustments made for them. And that includes the way that services operate, and that's to minimise the disadvantages related to a disability. So we need to adjust the way that we work to better enable the person to to make use of your service, essentially. And there's some good guidance. Again, I've put the links straight into the slides. So reasonable adjustments guidance for substance misuse in people with learning disabilities, and also the Applying All Our Health guidance, which is available across a whole range of topics, but there's a specific one around learning disabilities as well. So if people you're working with are, as in colleagues you're working with, maybe don't know about learning disabilities or don't understand kind of reasonable adjustments, these might be a good starting point to kind of make the case that you need some adjustments to how you're working. So in terms of how you're working, you can think about, are you using straightforward language? Are you explaining jargon? Are you using short sentences and giving time for people to respond? I think my sort of best example of this was someone I worked with in an inpatient learning disability acute unit, who just took so long to process and respond, and it didn't help that he looked very angry while he was thinking. But that was just him concentrating. But often we're tempted to fill the silence, or if they're not responding quickly enough, we're tempted to try and explain something to somebody again, and that might just overload the person with information, and it might also lead to kind of them feeling under pressure, potentially aggressive responses as well. So actually being able to sit with silence yourself is really important, to let somebody think, to allow someone to get to their own sort of conclusion themselves. Are you giving them information in writing as well? So long as it's safe, obviously, for them to have that information. So if people are living in vulnerable circumstances, if they're in domestically abusive relationships, if they're on the street, etc., actually some information you might not want written down because other people finding it might increase their vulnerability. But where possible, kind of helping them to have something that's a prompt to help them remember. Are you thinking about where you're having contacts? Are your environments kind of low stimulus, not too much distraction? Are you having shorter appointments? Are you giving them breaks? You might need to see someone more often, but for less time each time. How will they know that they can ask you if they need a break, or how will you know to read that they need a break in terms of reading their body language, and things. So having those conversations with them is really important. I think one of the term terms that often gets used around people with learning disabilities is acquiescence. So where people tend to go along with things, they don't necessarily feel like they have a choice. We're talking about a group of people who've often been disempowered. So if you tell them they have to come into a room with you and you keep asking them questions, they might not understand that it's okay to say, can I have a break, or this is too much for me. And sometimes then you might see that come out kind of behaviorally rather than just negotiating with you about how the session's going. Are you breaking tasks down into simple steps? So really thinking about, there's a lot of tasks that we really take for granted, that this is just easy to do because we're capable of doing it. But actually, if you've got cognitive impairment, you need things really breaking down, and you might need a lot of kind of scaffolding, a lot of support around how to do a task, and then checking understanding. So not just saying, do you understand? Because nobody wants to look stupid. They will just say yes, potentially. So instead saying, can you just repeat back what I've said? Or can I check, what have you understood from our conversation? Or what do you remember from this conversation? Those kinds of questions, so that actually it will become much more apparent much more quickly if they don't understand. And then in terms of an organisational level, I've put information about the Accessible Information Standard. If you're working in any health or social care settings, you're meant to have legally implemented the Accessible Information Standard. I think many organisations haven't done that. And that would include, have you produced kind of easy read information, or are you using easy read information from other places? You don't have to reinvent the wheel. There's lots of good stuff online. Have you got any questions built into your assessment paperwork about communication needs? Somebody may not understand or know their own communication needs, but it might be a starting point. And have you trained staff in communication awareness? So there's free courses that you can access that are fairly short, but just help you to think about, how am I communicating and what difference is that making to the person? If you go in and overwhelm somebody with information, they're not going to be able to readily engage with you. I'd also say this is just good practice. So I wouldn't I wouldn't say this is just something to think about and do if you're working with people with learning disabilities. Actually, this is just good practice. And if we're all working in these ways, trying to make our appointments and our language and our communication more accessible, that should work for more people, because there's all sorts of other groups of people who might benefit from this approach, who don't have learning disabilities as well. And then in terms of physical health, GPs should be offering an annual health check that's specific to people with learning disabilities, because of those known increased risk around physical health and reduced life expectancy. They don't all, but there's guidance online that you can help share if you're trying to advocate for somebody to have an annual health check. And also, if people are admitted to acute hospitals, as in physical health hospitals rather than psychiatric hospitals, there should be a learning disability liaison nurse. And again, there's nationally kind of available NHS information about that. So you can hopefully use that to try and find, if you've got someone they've got learning disability, or you strongly suspect it, if they're going to A&E, if they're admitted to a ward, trying to find out from the hospital whether they have a liaison nurse is a good starting point. They can help the team on the ward think about how they communicate with the person. Okay, then in terms of social care, so you may well be entitled to a needs assessment. Under the Housing Act, you've priority need if you're vulnerable due to a learning disability. So obviously that vulnerability's got to be there. So you might have a learning disability and be very much not vulnerable, in the sense that you've got good family or good support around you. You've got a good care package in place, so there you're not vulnerable. But if there is evidence of additional vulnerability, you should be considered a priority need, as says the Housing Act. Obviously, safeguarding is something that you might want to be thinking about where people are socially vulnerable. And I think, like Emily mentioned, cuckooing, and I think that cuckooing makes up about a third of referrals to SERAC, to the panel considering modern slavery. So thinking about safeguarding, thinking about capacity assessments under the Mental Capacity Act. Obviously that's relating to specific decisions. But if you think someone has a learning disability, that's a reasonable starting point for doubting capacity and starting to think about whether a capacity assessment might be helpful. And also in terms of police, so when it comes to police interviews, if somebody's arrested, if they have a learning disability, they should only be interviewed if they have an appropriate adult present. That might be somebody that they already know who can act on their behalf, but there's also people that are paid or volunteer appropriate adults who can come into police interviews. They shouldn't work for the police, they've got to be independent. But that's something that's really helpful, I think, for people to know and to not feel shy and kind of challenging the police about making sure that there's an appropriate adult present. I watched recently, there was a 24 hours in police custody where at least one, if not two, women with learning disabilities were being used to store drugs for a dealer, and it was very interesting watching the police interviews, and there wasn't an appropriate adult, but that is the guidance, that is the law, unless delay would result in harm to people, property or evidence, but often that won't be the case. And I think probably the most famous case of somebody with a learning disability being involved in a miscarriage of justice is that of Stephen Downing, who was 17 when he was convicted of murder because he found Wendy Sewell. She was still alive when he found her, and she died 2 days later. He was the caretaker of the cemetery, and she was attacked in the cemetery, and he served 27 years in prison before that was overturned. And part of the reason for that conviction was police pressure, inappropriate interviewing techniques, which we hope would not be the case today. But I think we can kind of think people may need more support if they've got a learning disability and they're in that high pressure environment of an interview, given what we know about kind of acquiescence and the likelihood that they might just say yes, or they might think that saying yes is the best way to kind of bring this situation of the interview to an end, but then obviously aren't able to kind of think about or understand what the consequences of that might be. So false confessions, and he did confess, albeit she hadn't died at the time. So obviously he confessed to the attack, and then 2 days later that was escalated into a confession to murder. So really, really important that people kind of understand their rights if they're arrested, and that we're able to support them in that. So a lot of what we've talked about is already in the Learning Disabilities and Homelessness Toolkit, but just to kind of flag a few other bits from it. So this is a toolkit that I put together with some colleagues, speech and language therapist, experienced professor in learning disabilities and homelessness, and rough sleeper commissioner from Westminster as well. And we also had somebody with lived experience involved. And we did this in recognition that the brain injury and homelessness toolkit existed, the autism and homelessness toolkit existed, but there was nothing for learning disabilities. And yet we know that people with learning disabilities are likely to be overrepresented in the homelessness population. So I just wanted to share a little bit from the person with lived experience, who we've called Dylan. Obviously that's not his real name, but he had some suggestions really about what workers need to do, which are likely to be helpful for other people. And I think what's really important is that he was able to sort of convey that it's his lack of feeling of safety, and his sort of feelings of vulnerability that are most important to him, more than kind of cognitive impairments or day-to-day kind of practical issues. So having workers who he can trust, who he can talk to, who can look out for signs that he might be being abused, and actually tell him about the concerns and how people should and shouldn't treat you, is really important. Sort of sharing information about mate crime, helping people understand the choices that they do have and what control they can take when it comes to kind of taking action to keep them as safe as possible. And I think like the suggestions that are listed there that came from Dylan, they're, first of all, they're good practice, but also they're not particularly difficult to do. So being able to show that you really care, helping somebody soothe themselves. Again, I don't think that should be specific to learning disabilities. Lots of people experience high levels of anxiety or emotional dysregulation, and actually being able to help somebody kind of soothe and regulate their emotions is really important. Helping somebody get involved in activities. Obviously, having some understanding of learning disabilities helps, but it's interesting that wasn't the kind of priority thing that Dylan put at the top of the list. And the other thing he kind of really highlighted was that the move to online services during the pandemic was really difficult for him, and that navigating kind of online meetings was tricky, and he needed kind of a lot of support with that. So thinking about how are we kind of encouraging people to have appointments, what support are we giving them, do they need kind of technological assistance, are they getting that, if we are working more online. Okay, so that's all information that's within the toolkit. So when it comes to thinking about kind of how do you intervene, how do you support people who have learning disabilities, I think the starting point is, does everybody in the system kind of know what learning disability means? Do they kind of get it? So we might find that systems around a person might be labeling them in all sorts of ways, either very explicitly or kind of more covertly, but thinking about people being seen as lazy or manipulative, or just they've been told, so why don't they know? I've heard that quite a lot, that I've told them, they know they shouldn't be doing this, or they know they shouldn't be behaving in this way, but actually they can't hold that in mind, and they need a lot of support maybe to to hold whatever information is in mind. So not getting caught up in what's somebody's personality trait, but understanding that it's the neurodevelopmental difference that's actually the kind of barrier to them being able to engage, or to them behaving in particular ways. Are you kind of adapting? Is everybody adapting the approaches in line with the guidance that I've given around reasonable adjustments, communication, etc.? And then another thing really important for the system to think about is, what's the stance of the treatment or the intervention or the approach that you're taking? So people with learning disabilities are often subject to kind of quite restrictive or paternalistic approaches, where people try and stop them from doing things. And obviously, I mean, first of all, there may be no kind of legal framework for you to be engaging in restrictive practice, trying to stop them doing things, trying to stop them going out, holding their money for them for their own good. There's some kind of common sense things, or things that seem common sense, like looking after their bank cards so they can't be exploited by somebody else. But actually, that's a short-term solution. It's not helping them learn the skills longer term to kind of manage their own finances. And we don't have any right as professionals to limit people's freedoms unless they're very specifically subject to deprivation of liberty safeguards, which probably for the group that we're kind of thinking about today, they probably won't be. Maybe people with more severe learning disabilities, that's more likely, and who are living in kind of care homes where those restrictions can be workable as well. Also, are we kind of recovery focused? Are we trying to help them build their skills? Are we trying to help them achieve what they want to achieve, greater quality of life, greater independence? Or are we very risk focused and we're telling them they should kind of keep things as they are? Because that's better than taking the risks that you need to take to, develop in life. Are you all kind of coordinating care plans and integrating them? So if somebody's open to mental health services, substance use services, community learning disability team, homelessness service, actually, have you all got together and come up with one care plan that is simplified for them and communicated in a way that they understand it? Or have they been given 4 or 5 different care plans from different services that might all say different things? Are you thinking about how you integrate so you can give them structure across a week so that different people have their appointments on a set day so they develop a bit of routine, those sorts of things? Are multidisciplinary reviews taking place? Are you getting back together? Are you seeing how things are going? And is there an advocate to support the person's involvement in that process, or are you able to involve them? Again, I think like the sort of bottom few points on that list are good practice. So I don't think they need to be specific to learning disabilities. We should be thinking about sort of stance of our approach, whether we're coordinating care plans across services, whether we're reviewing, and whether we're involving people regardless of whether they have learning disabilities or not. But they're certainly things I'd want to see in support for people with learning disabilities. So in terms of what we can all do, obviously, please read the toolkit and share it with relevant services, both kind of homelessness services and learning disability services. Having worked in community and then inpatient learning disability services for about 6 years, I'd say we didn't talk about homelessness. We weren't in touch with homelessness services. We were waiting for referrals to come to us. We weren't kind of reaching out to kind of local hostels or things like that to think about whether there were people that might benefit from support or assessment. So I think it works in both directions, both homelessness services supporting learning disability services and vice versa, to understand each other's services, but also populations. There's lots of resources in the resources section in the toolkit, so have a look at those. I think always holding it in mind as a possibility, that kind of inculcating, setting the idea that if you've got somebody that you're really struggling with, they just don't seem to be making progress in the way you might expect, and there's not an obvious other explanation for that. Or even if there is, could there also be a learning disability? Holding it in mind, thinking about it. Connecting with each other, local services and commissioners, thinking about how do we hold this group in mind, advocate for them wherever possible, and kind of where needed, escalate as well. So if there's like a main professional and people are doubting or insisting that someone doesn't have a learning disability, but you're fairly confident based on the sorts of things that we've talked about today that it could be an issue, I think you've always got to be open-minded to the possibility that you're wrong, haven't you? But advocate, push it, talk about why, help somebody get the kind of assessment if it's likely to benefit them in the longer term. Okay. And I think that's us. So I'm going to stop sharing and we can come in for questions and any comments. I've seen Chloe's put a thing in the chat around nice guidance on LD and homelessness. Sorry, I wasn't clear. It's homelessness, nice guidance. It's not specific to learning disabilities, but obviously it might be quite helpful for learning disability services where you're working with someone that's homeless. But I can put that link in the chat.
Oh, thank you, Anna and Emily, for that. So we've just got a couple of questions at the minute. So if anyone else has got anything, if you just pop those in the Q&A box, please. So the first one was just regarding when you were talking about appropriate adult in police interviews. So just ask if you suspect a learning disability, but it's not been diagnosed yet, can someone access an appropriate adult in police interview, or would they need a full diagnosis?
That's a good question. I don't think you have to have a diagnosis, but I'm not 100% sure. But I think if you have that suspicion, I would definitely be talking. If you know someone's in custody, I would be having a conversation with the custody sergeant about it, about whether it's an option.
Thank you. So the next question says, what kind of support, aside to the assessment, can learning disability services offer the people we support?
So quite a lot. So community learning disability teams are multidisciplinary. They tend to have psychiatry, psychology, nursing, speech and language therapists, occupational therapists. They used to have physiotherapists. I'm not sure if that's the case anymore. Am I missing anyone, Emily, discipline-wise?
Did you say community nurses? I think you did, didn't you? Yeah.
Yeah.
But yeah, physios were still there a couple of years ago when I was there. So yeah.
So it should be very much kind of needs led, obviously. But usually CLDTs are working with people who've got either significant mental health problems alongside with their learning disability and or challenging behaviour. But they would take an approach that challenging behaviour is usually the result of needs not being met. So using positive behaviour support and other approaches to think about why somebody is kind of needing to behave in that way. So certainly psychiatrists may be involved in terms of mental health. Therapy can be an option. We recognise lots of people, we didn't really talk about this, but lots of people with learning disabilities are at much higher risk of psychological trauma than people without learning disabilities because of social vulnerability, abuse, care home settings, physical restraint, all of those sorts of things. So therapy can be available, dementia assessments. So some people with learning disabilities are more likely to get dementia earlier in life. Occupational therapists can do a really wide range of things in terms of supporting people with developing their daily living skills or trying to think about what adaptations somebody might need to do more and do it more safely. Speech and language therapists, I think Jade's on the call, so she might want to say more about that than me, but thinking about communication needs. And again, that's not changing them, it's changing how we talk to them so that they can better understand, whatever it is that they need to understand. And then community nurses get involved in all sorts of things, so behavioural support and kind of assessment, but also obviously think about physical health needs. We find that things like undiagnosed urine infections can lead to a really rapid deterioration in behaviour and really unusual presentations. Helping people to think about their physical health needs and how they care for them, but also kind of support to access mainstream services. So things like overcoming needle phobia, for example, might be a piece of work that a CLDT does to support somebody to be able to then have routine GP appointments. Emily, do you want to say more? Because you have spent plenty of time in CLDTs as well.
Yeah, I think there's a huge overlap often between services. I think, like you said, it's very multidisciplinary. And from when I worked in the NOTS LD team, yeah, I think it was very sort of, what's the word, like collaborative between psychiatry, psychology, OT, nurses, physio as well. I think, if I remember rightly, there is a dietitian service, but it's quite specific in how it's accessed.
Yeah, that is right.
I think you have to be within the service already, but there is that if there is ever a need for a dietitian as well. Yeah. But yeah, I'd say it's a very collaborative process, and there's lots of usually ongoing meetings regarding people's care and how best to support them. And when I think those things are put in place, it's disseminated across people that are working with people very well.
Yeah, thank you. I've also got the answer to the appropriate adult question, which is that vulnerable people, they should support vulnerable people. So I don't think you have to have a diagnosis. So I've put some guidelines on there about that.
Oh, thank you for that. So the next question, it says, if somebody has a traumatic head injury that affects cognitive learning or cognition and learning, sorry, but it wasn't there since birth, what is it classified as?
It's not a learning disability, so that is an acquired brain injury. Yeah.
Okay, thank you. I think that's the end of the questions, unless anybody else has got anything that they want to just pop in the Q&A box.
I guess just to say about kind of traumatic head injuries or brain injuries is, like, a lot of the recommendations for good practice for people with learning disability are very, very similar, because ultimately it's cognitive impairment. So, we'd still be recommending all the things that we've talked about in terms of adapting your communication, reasonable adjustments, written information, more reminders, all of those sorts of things are things that we would still be recommending, whether it's brain injury or learning disability.
Thank you.
And I've just seen the question about where to access the toolkit, so I will pop that in the chat. It's on the slides, but I'll pop it on the chat as well.
Thank you.